So I'm going to talk about staging a little bit, and then we'll get into more treatment things. Dr. Linden's here. He's going to talk about skin-directed therapies, and then later I'll talk about systemic kinds of therapies and new therapies that exist. So as I mentioned before, if you go to a meeting where they're talking about all kinds of lymphomas, they'll talk about a staging system that doesn't relate to skin lymphomas at all, so be a little careful. And you might ask, why do we even stage people? What's the point of it? So you'll see one reason we do staging procedures is to figure out what the appropriate treatment is, because different stages require different kinds of treatment. It might tell the physician and the patient a statistical idea of what to expect, but we have to realize that statistics don't mean anything to the individual. So if you look at a survival curve or something, you go online and you look at these things, you have to realize that that doesn't really mean anything for you as an individual. It's just kind of a general kind of explanation of how these diseases go, and they change over time. So if somebody went online and saw survival statistics for mycosis fungoides, they're at least 20 years old, if not more, and none of us that do this all the time believe that that's what happens to people anymore. It just hasn't been revamped. Another reason why people do staging is to be able to know after somebody's treated, how did the treatment work? So if you didn't know where it started, then you don't know where to look. So that's another reason. And the fourth reason is that when we're doing clinical trials, we have to have like participants in order to understand how something works and to be able to compare it to something else. So as an example, maybe a trial only allows people that have stage 2B or beyond. And that's because A, they think that's an appropriate therapy for those people, but B, so you could compare it to other trials and kind of see which drug might work the best in different populations. So that's another reason why we have stages. What we don't know about from stages is one thing that I told you: it doesn't tell the individual how they're going to do, because it's a statistical construct. So that means the average is going to be here. Some group of people is going to do extraordinarily better than the average, and some smaller group of people maybe do worse. And we don't know who those people are going to be. The thing about mycosis fungoides staging, which is really important, is somebody made it up. They made it up because at the time, the National Cancer Institute was using something called Tnm staging. And this was at the time that they were figuring out the staging for mycosis fungoides. They made up Tnm stages, which I'll show you, but it in no way means that somebody goes from one stage to the other automatically. It's not like that. They were stages that were designed what's called empirically. They made them up. And they made them up so that they were usable and so that they would discriminate against different groups of patients, ones that would do really, really well and maybe some that wouldn't do quite so well. And that's really how they did it. So a lot of people that are stage 1 go, when am I going to be stage 2? Maybe never. Hopefully never. It just doesn't work that way for this particular set of disorders. So as I mentioned, T cells go through a circuit, and they go through the blood, they go through the skin, they go through lymph nodes. So when we're doing staging, particularly for mycosis fungoides, we look at the tissues where they go to see if there's involvement. So that means we spend some time looking at how the skin looks. We do some assessment of lymph nodes. May only be an exam, but we do some assessment. We might do an assessment of blood, and we might do an assessment of other organs, and that may just be examining somebody. So for the skin, you could do photography. I'm not so good at it, but dermatologists are really good at it. They're really good photographers. We might document the extent and the type of skin lesions by photography or drawing pictures or some other means. Lymph node-wise, we're for sure going to examine. Some people are going to get scans, not everybody. We might choose to biopsy the lymph node if we're suspicious that it's involved. Looking at the blood, we would do complete blood count. We usually do liver tests. We do a test called LDH. It's not your cholesterol. It's lactate dehydrogenase. It's a tumor marker for lymphomas. It works for every lymphoma. Sometimes, at least the patients I see, are all tested for HIV and HTLV1 because there's these associations, and I don't know who's HTLV1 positive unless I check. Not everybody's from Japan. Some people get it in more complicated ways. And I usually do flow cytometry on somebody initially. And in terms of looking at other organs, primarily I'm examining people, but some people are going to get scans. They're usually the people that have more advanced disease. And at this point, we very, very rarely do marrow examinations, but there may be some indications for it still. So this is the TNM, and there's a B part. So the T, it stands for tumor. It has to do with the person's skin. This is for mycosis fungoides. It's all based on what somebody sees with their eye. Now, having said that, I've participated in groups many times where we passed around either pictures, or one time we passed around Play-Doh on pieces of wood to simulate different kinds of lesions, and asked all these people, 20 people that only do this all the time, what would you call this, a patch, a plaque, or a tumor? And not one of us agreed with each other, but we agree with ourselves. So when we're looking at this staging, it's a little subjective because my tumor may not be somebody else's tumor. But this is in fact how the skin goes. T1 through 4. T1 and 2 are patches and plaques. Patches means you can see the lesion, but if you close your eyes and run your finger over it, you may not know it's there. It may not have that much thickness. A plaque has some demonstrable thickness to it, so even with your eyes closed, you would feel there was something there. A tumor, you know, my definition of a tumor would be kind of a dome, usually a dome-like structure that has some thickness to it. And then T4 is when patients are all red. And some people have a form of mycosis fungoides where they're all red. On the node side of things, it's actually a pathologic staging system. So it relies on a node being removed, if that's been done, and a pathologist grading it as to how much involvement it has or not. It turns out that the only important thing is if it's real obvious for the pathologist to see that there's mycosis fungoides in the lymph node. If they have to do all kinds of fancy tests to show it to you, it actually doesn't mean much to the person. Organ involvement we do based on exam and blood tests, and then blood involvement is done usually based on flow cytometry, and there's different gradations of blood involvement. So I will mention that people that are stage 1, they're divided into A and B. It has to do with how much of their skin's involved, and the break point is 10% body surface area. So it turns out that your palm is about close to 1% of body surface area. So the way we figure it out, it's just the same way they figure out burns, is to figure out, can you cover up, how many palms does it take of the person's palm to cover up all the lesions? And that's how you figure out what percent body surface area. 10% is actually quite a lot. It surprised me when I first saw how much 10% was. So when you have these TNMB staging systems, you have certain criterion, and then it's like stage 1 or stage 2. So it turns out stage 1 means the person has patches or plaques, and then it's A or B. A is less than 10% body surface area, and B is greater than 10%. Where did they get the 10%? Got me. I wasn't there then. I don't know that part. 2B is somebody that has tumors. 3 is somebody that's all red. It's now broken down into you're all red, but you have a little or a lot of blood involvement. So when somebody has a lot of blood involvement, actually the stage now is called 4A1. That's where people that have Sézary syndrome, that's where their stage is. 4A2 has nodal involvement, and 4B has some kind of organ involvement. So that's kind of how the stage goes. And it turns out that most of the people that are diagnosed in the US have early stage disease, have stage 1 disease. That's just the way it is. Other skin lymphomas also have a staging system, but it's not really used very much. But we go through the same staging procedures as we would for other lymphomas. That means we pay a lot of attention. I would for mycosis fungoides too, but whether they have so-called B symptoms, that means fevers for no good reason, really profuse sweating, particularly at night for no good reason, and a significant weight loss. I would examine in the same way. I would still get my blood counts. I still get my chemistry and LDH. But there, when we're talking about B-cell lymphomas, we'll often do scans to make sure that it's not a lymphoma that's elsewhere and just happens to show up on the skin first. And we might do PET-CT scans. We may do other testing like bone marrows, depending on the person. And as I said, there's a complicated system for looking at skin lymphomas that aren't mycosis fungoides or Sézaries. I don't know if anybody ever uses it, but somebody got a publication out of it. So I'll just tell you it exists. I wouldn't use it. It's very cumbersome. It has to do with how far away the lesions are, and it's kind of a mess. And since I didn't bring along today somebody from radiology, I thought I'd just go through a little bit PET-CT scans. Who's had one? So a fair amount of people. Do you understand what they are? Nope. Okay, so here's a machine, and it has incorporated in it both the ability to do the PET portion of the scan and the ability to do the CT portion. They're really different. So I'll try and show an example. This is a CT scan. CT scans are fancy kinds of X-rays. The machine has the ability to turn somebody on their side. So you're looking at somebody's chest here. And let's see if I can get the, okay. And, all right, this is their back, and this is their front. And this is it's called the mediastinum, the area where the heart and the big vessels are. And then these are both their arms. So what a CT scan does is it turns somebody on their side, and it makes a picture as if you were slicing the person. And then you turn them up in, like what's inside. They're beautiful pictures. So on this, you can see all these things here. They're all lymph nodes that don't belong there. So somebody would say there's a lot of lymph nodes. So that's the kind of information you get from CT. Is very anatomical. They're very good pictures. They can put measurements on the lymph nodes. But what they can't do is tell you if there's something active in that lymph node or not. That's what they can't do. So that's where a PET scan comes in. PET scans, for those who've had them, you know that they inject something into you. The person comes and the thing's like in a lead box. It's pretty exciting. Why is it in a lead box? Because it has something that emits particles that the scanner is going to pick up. They inject it into you. It's sugar, basically. It's sugar, and it has something tagged onto it. So it's going to go right for anything in your body that's sucking up sugar. So what's sucking up sugar? Anything that has cell division, because sugar is the currency of all cells. So they usually don't have your brain in the picture, because we hope that all of our brains are sucking up sugar all the time, that it's using stuff. It will show up your heart, which is what this is here, because the heart is a muscle, so it's sucking up sugar all the time. This is the person's bladder as the sugar gets out. But this stuff doesn't belong. That's all those lymph nodes. So it doesn't necessarily mean it's lymphoma. It's something that's causing the lymph node to be hypermetabolic, to metabolize too much, to suck up too much sugar. It could be an infection. That would look like that too. So somebody would actually have to do a biopsy and send it to the pathologist to know exactly what it means. But in the lymphoma world, if we know that a lymph node had lymphoma in it, till proven otherwise, it means there's lymphoma here. And this is the person after they're treated. It's gone. Now on the CT scan, if we were going to get a CT scan at this point, we might still see some of those big lymph nodes, but they're just dead now. They just have junk in them. And there's nothing live or active, and that's why we use PET and CT, because you can see the PET's not a very nice picture. It's very grainy. It's not so nice. So the PET tells the radiologist where to look, and then on the CT scan they look and tell you what's taking up the sugar. That's how you use those.